Yes.
Awesome. Okay, so I'll get things going with just a little bit of information about the Champlain Hospice Palliative Care Program. So that is me. And so our role as the Champlain Hospice Palliative Care Program is quite broad. We do not deliver direct clinical services. We're really in the game about supporting the people who do. So we'll work with healthcare providers across the Champlain region in any setting to help support them in the work that they do in providing care, palliative and end-of-life care. And so, yeah, this just gives a sense of our geography. We go from, Deep River south to kind of Kemptville area and east to the Quebec border. We include Carleton Place, but not Smith Falls, because that's a really interesting delineation. And we have a team of kind of 3.5. There's Carl, who does work around education and communication. Tara Cohen, who has a social work background, who does a lot of work with grief and bereavement and supporting long-term care homes around implementing a palliative approach to care. We have Ruth Richardson, who works with us part-time, and then myself as a director, and I have a nursing background as well. So just a quick reminder from the session last week, you'll be hearing about this palliative approach to care. We'll be banging you over the head with it. Just that idea of, it's an approach to care that is appropriate for people regardless of the stage of the illness that they're living in, regardless of age. Really, the focus is on improving quality of life. And that idea of it's a holistic approach to care. So, certainly when I think about the residents of retirement home, and I know a lot of the work that you do is actually, that palliative approach to care. And then, thinking about as well the differentiation between end-of-life care, which is really the care that we see closer to the time of death. So the Champlain Hospice Palliative Care Program, as I mentioned, we help to support healthcare providers. We're providing care in home and primary care, and I know Debbie and Genevieve will get that, lots of coverage, as well as hospital-based teams. So certainly in our region, we have hospital-based teams at the Montfort Hospital, the Ottawa Hospital, as well as the Queensway Carleton Hospital, and then some as well in some of the smaller hospitals. And then in terms of palliative care beds, we have the beds out of Briere, which is now moved to the St. Vincent site of Briere, as well as beds at the Ottawa Hospital. We do a lot of work, as I mentioned. Tara Cohen does a lot of work in supporting long-term care homes with the work that they're doing around implementing a palliative approach to care. So we'll provide education and supports to long-term care homes who are looking to improve their practice in that regard. And then finally, hospices as well. And so we have a number of hospice beds across the region. And I think in one of my later slides, I've got a little map that shows where they are. And some have beds. Others have community-based services that include things like day hospice, volunteer visitors, grief and bereavement supports. And those are all services that your retirement home residents could be taking advantage of as well. So important to remember that the hospices are out there and can be helping you in the care of your residents. So this is just a little map of the hospices, as I indicated, and we have, it's an interactive map. And so when you click on it, you can click and see what are the hospices that have beds, what are the hospices that have community-based palliative care services, and then the palliative care unit. I won't click on the link because I want to make sure we save plenty of time for Debbie and Genevieve. So now I'm over to Genevieve. So we talked about those hospice-based services, and I'm going to, turn things over to Debbie to talk about home and community care support services.
Thanks so much, Val. Great to see some familiar faces on the screen, and just want to welcome everybody. So for some of you, this will be familiar information, but just wanting to share a little bit about home and community care. Next slide. So really our goal is to help support people, and I say patients as well as their families in the Champlain region, but for home and community care, we're actually right across Ontario. We do a lot of collaboration with our patients, their family members, our service providers, our partners as far as hospitals, hospices, even long-term care, and of course, retirement homes. So very happy that you're here. We're hoping that we can continue to build relationships and really help improve the patient care delivery. Next slide. As Val had indicated in her previous slide, just with regard to the area that we serve, it's kind of Barry's Bay to Deep River, right out to Hawkesbury. On the PAL team, we actually cover right across Champlain. So we have about 25 care coordinators who specialize in palliative care and provide great care right across the region. But Champlain at a glance, there's just some information here as far as the area, the population, the language. The service providers, we have 11, but for palliative, we have in the Champlain region Access, Care for, SE Health, and Bayshore, as well as at-home hospice. And Genevieve will talk about some of the care provided in the long-term care from RPCT. Next slide. So really what we want to do, I say, as far as home and community care is to provide that safe care that people can remain at home. So whether it's their own home or their retirement home or long-term care, we can help support them with what it is that they need as far as nursing, personal support, or other therapies. If we're able to help keep them out of hospital, that's great. If we can help them leave the hospital, even better. So again, one of the big goals is to see what we can do to help them with their needs. Where possible, where those patients do require a family physician or even a specialist or nurse practitioner, we can aim to help support that as well. We do have a group that helps facilitate long-term care placement or supportive housing. So that's another specialty that home care provides. I've already mentioned about avoiding ER where possible, and also linking them up to community services, again, for whatever it is that they need pending their assessments. The big goal for us is really to help enable people to remain in their place of choice and to help them die with dignity. Next slide. There is eligibility criteria for us. So patients need to have a valid OHIP card. Their needs cannot be met on an outpatient basis. Professional services, it could be nursing, social work, therapies, and we do have the option of clinics, but most of our palliative patients are not able to access the clinic, but there are some that can. Next slide. Care coordinators, I'm sure there's many of you on the call here, so it's great. This is really just to highlight the great work that the CCs do. They are regulated healthcare professionals, so they could be nurses, they could be therapists as well, or social workers. On the PAL team, all our care coordinators are nurses who have a specialty in palliative care. They do go out to see the patients or the residents wherever it is that they are, be it in their own home, the retirement home, or even the hospital. They do work with the patient and family to identify what those needs are and create care plans that are specific for that individual. They help coordinate the services, work with the other service providers, the other healthcare professionals, and really link them up to what it is that they need. And if it's necessary, they will help with the eligibility piece for long-term care. So we do provide a lot of in-home care. As I mentioned, we do have clinics in the community as well. Palliative really is, I'm going to say, a specialized program. And we do a lot of great work in the community, in people's homes. We do a lot of collaboration with the retirement homes, with the programs, certainly with RPCT, with the MAID network, our hospital partners. Wherever it is that we can spread the good word about the benefit of palliative care, we like to do that. So at home and community care, again, for many of you, you'll already know this. So as I've already mentioned, some of the services that we do have. So this is just here for your reference. One of the other programs that we do have is the telehome care. So for the patients that have CHF or congestive heart failure or COPD, they're able to access this telehome care, again, to help with the symptom management piece. Help trigger if there are issues surrounding the symptoms, that they may get a call from one of the rapid response nurses, and even a reach out to the physician. There's a lot of education that happens. Genevieve will talk about RPCT later, but for home and community care, we do have 7 nurse practitioners that to work specifically with the regional palliative care consultation team, and they really help in collaboration with the Briere group to help support patients, again, wherever they are in dealing with their serious life-limiting illness. So a lot of very detailed assessments, helping them deal perhaps with the diagnosis, advanced care planning, pain and symptom management. They may order lab and diagnostic tests. They'll also prescribe medications where necessary. They do work a lot with the physicians, really helping build capacity. So for palliative care, Val's already mentioned about what it is that the approach is, but really for our team, helping support the pain and symptom management for that patient, as well as the family, because it can be a very difficult situation. And again, helping people to remain at home for as long as possible, again, depending upon what it is that they're able to manage, but also what is their preferred place of death. We do see patients early on, sometimes even at diagnosis, help follow them through that journey. And not all the patients requiring palliative care are actually on the PAL team. We do have a lot of great care coordinators within the organization who will help in the care coordination of their patients who are needing a palliative care approach, but who may not need the complex care management of the PAL team. Again, we do link up with the other groups with regard to respite care or day hospice. We do a lot of work with the hospices surrounding equipment lending, or even the visiting volunteer program, the day hospice. It could be caregiver support, just for the outpatient basis. And then also a lot of work Val mentioned about the hospice residences. So for those patients who are not able to remain at home or do not want to remain at home for end-of-life care, we do a lot of collaboration with the residents piece. And if you can imagine, there's a lot of work that still needs to be done with regard to education, counseling, and emotional support, not only for the patient, but also for the residents, not only for the patients and the families, but also the care providers as well, or even the service providers. And also even what we're doing here today, just with regard to providing that education for the retirement home staff as well. Again, our care doesn't end when the patient dies. We do provide a follow-up with regard to a condolence call, but also linking them up with bereavement support and other community resources. For those patients that are receiving a palliative care approach, they do have the chart in the home, or the SITH, which is the black binder that hopefully you're familiar with. It is a great communication tool that everybody should be documenting in, that will help with the pain and symptom management piece, the collection of the information on medication, but also specific symptoms. And it is a great way to be able to communicate. The families and volunteers can even chart in this as well, to help people truly understand, what's happening on a day-to-day basis with the patient. We also have the symptom response kit, or the SRK, that is specifically to help, I'm going to say, patients or residents with the symptom management particularly for end of life. It's kind of that crash cart in the home type thing that has specific medications and supplies, including Foley catheters for that end of life care. And as I mentioned before, we do a lot of work collaborating with the hospitals, with particularly those that have a palliative care team within the hospital, but also identifying if there are opportunities to help with discharge planning and making a smoother transition from hospital to home. A lot of work that we do with the variety of hospitals right across Champlain, and also the palliative care units at St. Vincent's, as well as Marion Hill. The hospital care coordinators, again, that's really just for future reference in the event that you're interested in more of what those care coordinators do, and the rapid response nurses as well. Again, if living independently is no longer possible, we also have the option of those care coordinators that will help out with long-term care placement or assisted living, or even needing to access retirement homes. And again, many of the care coordinators that are on this call are able to assist with that. So we're open to questions, conversations, if you're needing direction with regard to that as well. As we're also here to help if there are things that questions that are kind of percolating just with regard to change in condition, or if there's something that's identified as a need and you just have a question, you can certainly reach out to the care coordinator who's assigned. But even if the patient themselves does not have a referral to home care, that can be arranged, and the contact information is here as well. Again, community resources. This is our Champlain Healthline. There's a great list of resources that are on here. I've included this purposefully so that you have access to this information. There's a lot of good resources right across Champlain that you can certainly access. And again, another resource, the healthcareathome.ca. If you're wanting to make a referral, you're looking for forms, this is where you're able to find this information. And the big part of what it is that we do is really the customer service piece, or being able to listen to the people that we serve as far as what it is that they're needing, collaborating with them with regard to making a very patient-centered care plan. We're providing opportunities for feedback, and if there are any changes that need to be made, and I'd say not necessarily just negative things, if there are compliments that you want to share, or families want to share, patients want to share, we have that opportunity as well. But if there are any concerns, it is something that we take very seriously. We want to make sure that we're providing the best care possible. And so we do have the opportunity for feedback with regard to that, because we always want to make sure that we're doing the best that we can, particularly for the vulnerable population that we serve. And over to you, Geneviève.
Thank you, Debbie and Valerie. Hi, everyone. So please excuse me. I do have COVID. I'm fine, but my brain is a bit foggy and I sound very congested. And then sometimes I just get a big shortness of breath bout. So I'm going to try to do my best for this presentation. I'm hoping most of you know about our team, so I'll do a quick overview, and hopefully we have some time for discussions and questions at the end if there's anything you need clarification. So RPCT is the Regional Palliative Consultation Team. We are a team, we have doctors on our teams, registered nurses, specialists, nurse practitioners. So as Debbie mentioned earlier, we are a combined team. We had a marriage many years ago. So we have staff coming from Brier Continuing Care, and then some staff coming from Home and Community Care Support Services, Champlain. So we work as one team, just with two organizations. We are consultants, and this is kind of a a big thing for our team because we don't take over the care of palliative patients in the community, but really provide support and consultation, advice to their primary care teams. So that is to their family physicians or primary care nurse practitioners, as well as visit nurses, care coordinators, and anybody else who's a member of their team. So this is us. You may recognize some faces. I don't know. Maybe without wearing masks, none of us will look very familiar. But this is the most recent team picture we have. Go ahead, Val. Sorry, you can move the slides. All right. So yeah, so I mean, our goal is really not to do all the palliative care. We are small and mighty, but not that powerful. We do cover the entire Champlain area, so all the way from Hawkesbury, Cornwall, and then on the west end, you know, Pembroke Deep River. We go to Barry's Bay. In the south, we go all the way to the St. Lawrence, and then Carleton Place is kind of our south limit there on the more western end. So you know, we are involved other than doing the consultation work with patients and families. We do offer a lot of formal teaching. So you may have been in some LEAP sessions facilitated with our PCT consultants. And then, you know, we are also involved in sort of more informal teaching and mentoring. So every time we do home visits, we really try to do them jointly with visit nurses, with retirement home staff, with family physician, and then we just like to all learn from each other. So us from you and you from us, and so on. Again, Valerie, and in our last session last month, we talked a lot about a palliative care approach, like early in the disease trajectory. So our services are not just for patients at the end of life, but really for anyone having palliative care needs. Again, when we do a consultation, we help with not just symptom management, but also advanced care planning, goals of care discussion. You know, obviously the care coordinators and the retirement home staff are very involved in the care planning, but we do also support that. If any of you have seen our consultation notes, which are sent to our service provider organization, so the agency nurses, as well as if the patient's in a retirement home, we'll send it to the retirement home directly. So we try to really detail our notes that, you know, when we're giving recommendations, people do understand why and the rationale behind it. And hopefully we can kind of all be on the same page and all learn from this. As you probably know as well, we're available 24/7. We prefer to get calls directly from nurses, from retirement home staff, from family physicians and the teams we support, just because we don't have the capacity to go visit patients 24/7. So we'll really rely on your assessments when you call us after hours. So again, we really like this triangle because we know there are a lot of patients with palliative care needs out there. And obviously, like specialist palliative care teams, you know, cannot provide all the palliative care that is needed out there. So we know that, you know, that those patients that may have lower kind of complexity in terms of their needs, you know, anybody can provide a palliative approach to care that goes from, you know, their family physicians who always have, you know, a certain amount of sort of basic to medium knowledge in palliative care, their care coordinators as well, their nurses who sees them, their PSWs, like, right, everybody's part of the care team and can meet their palliative care needs. So we tend to get maybe a little bit more involved when their care needs are a bit more complex. But yeah, this triangle, I think, is kind of a nice way to for all of us to feel like we all need to be involved in the palliative care delivery. So what are our criterias? We always kept them fairly vague, which we're kind of proud of and we like. So we will see really any patients with a life-limiting illness. So they can have a cancer diagnosis, but also we see a lot of patients without a cancer diagnosis that may have other organ failure, such as heart failure, end-stage COPD, end-stage liver failure. We do see patients with dementia and frailty. What needs to be in place is they need to have home care nursing in place, usually through home and community care support services. However, in certain facilities, especially in long-term care, they won't have home care services, obviously. In some retirement homes where there's 24/7 nursing, sometimes we can make exceptions to that, but usually they'll have a nurse involved from a service provider organization. And then usually they will need to have some sort of symptoms that are difficult to manage. And when we use the word difficult, we're not meaning necessarily that they're extremely difficult to manage or extremely complex, but that the team looking after them is having some difficulties with symptom management and need sort of our support in this. And or maybe we're also struggling with sort of advanced care planning and goals of care discussions, and the team needs our support. So we don't have a PPS criteria. I'm sure everybody's familiar with the Palliative Performance Scale tool. So they don't need to be bedbound or 40 or below or anything like that. We don't care. We see them sometimes they're quite ambulatory, but they may have palliative needs that need our attention. They don't need to have a DNR. Like, we will have conversations around DNR and goals of care, but this is not mandatory for us to be involved. It's also not based on prognosis. So our team have been following people that sometimes for many months, and some for maybe a year or two or longer. It's quite rare because often if they're that stable, we may discharge them and may get re-involved later on. But for some patients that may have like high symptom burden and but a longer prognosis, we will stay involved. Just so you know, we don't see patients for chronic pain management or geriatric psychiatric issues. This is not our specialty. So, I mean, it's not like we have no knowledge around chronic pain or geri psych, but they are teams more equipped to deal with these patients. So again, if someone someone needs a palliative approach to care and they also have chronic pain issues, then obviously we'll be addressing them together with their primary care providers. But we're not going to take referrals simply for chronic pain management. So there's a patient sort of criteria, but we also, because again, we're consultant and we are here to support their care teams, patients do need to have a primary care provider. So as I said earlier, most of the time they're family physicians, but sometimes too they're primary care nurse practitioners. So these primary care providers need to be sort of willing and able to really provide palliative care to their patients, including care at end of life. They are usually available to us after hours, or they have after hour coverage for urgent issues. Now, that being said, that can be very scary for primary care provider to kind of feel like they have to be on 24/7. So, we try to put everything in place that, we minimize the amount of times we have to call them. So that will include having a symptom management kit in place, like Debbie talked about earlier, having the expected death in the home protocol filled out. So, when a patient dies, they can be notified sort of the next, day during the day or the next business day. And we do also have backup in terms of if they're away for the weekend, and we do have nurse practitioners and physicians we can reach out to if we need sort of more urgent orders. As I said, the primary care provider will be responsible for signing the death certificate. So we need to have a primary care provider involved in the care of these patients in order for us to get involved. So how to refer, we've put a link here, which is not very helpful on a on a on a PowerPoint presentation that you can't click on. But if you actually Google Champlain RPCT, you'll land on a website that will give you our referral form, and we can get referrals from really anyone. So it doesn't have to come from the family physician, for example. So we have long-term care homes and retirement homes sending us referrals directly. It often comes from their primary care providers, sometimes from their specialists, and then a lot of them too from home care coordinators and their home care nurses. We'll do our best to see patients that have urgent needs within just a few days. And we put 2 to 5 here because we do have to be careful and not setting expectation that we can be there in an hour. But usually if it's really urgent, we probably will be there before 5 business days. And then stable patients can take a little bit longer. During that period, while we're waiting for us to get there, we're still available 24/7 and can help sort of, on the phone with the information you have, try to figure things out until we can get there in person. I always say to people, if you're ever in a bind and you have a patient who doesn't have a primary care provider, or you're not too sure if the primary care provider can work with RPCT or can provide sort of palliative care, just send us a referral anyway, or give us a call. Chances are, if there is a family physician in place, we have a large roster of family physicians with really good notes on them, and would probably know if we work with them or not. And then again, if they don't have a family physician, sometimes we can find someone for you in the area. Now, in retirement homes, obviously, most of the time, or it used to be the case, you have an in-house physician, and for most of them, they do work with RPCT. But we know the last year or two have been quite challenging in terms of availability of family physicians, and we know that some retirement homes have lost their family physicians, have not been able to replace them. So if you're ever really stuck, just give us a call, because we might be able to help there as well. I'm going to go over this quite quickly because I think I've touched on a bit of this, but when we do get involved, this is what we do, right? So there's obviously the sort of symptom assessment, physical assessment, but we do address goals of care and care planning. We are involved, just as you are, with sort of a bit of education around palliative care, end of life care, reviewing expectations. And then I think I've covered the rest. We do follow-up assessments. It's on a as needed basis. So we'll do an initial visit, and then we'll just work with the healthcare team and patients and families in terms of what follow-up, what frequency of follow-up and intensity of follow-up is necessary. Again, we do like to do joint visits. So if you ever hear that we're coming to your facility and you want to join us, like whether you're, a nurse at a home, if you're a care coordinator, if you're a director of care, it's always very nice to do the visit jointly, because you do sometimes have like way more knowledge about the patients than we do. So that's always very helpful. When we do go to retirement homes, we'll obviously usually stop at the nursing station, get a medication list, and probably chat with you around sort of any information, any clinical information you have that might be helpful for us when we meet with the patient and their family. Again, that's going back a little bit on, the fact that we don't just serve the cancer population. So, and this is something we're also very proud of. We know that a lot of palliative services throughout the world and throughout this country actually is mainly serving cancer patients, but we've really kind of expanded to, and that's probably because we don't have like sort of a prognosis or PPS criteria to for our team to get involved. So we see patients with other illnesses. So here we are. This is our numbers for healthcare providers. We do ask patients and families to usually contact their, well, if they're in a retirement home, obviously to talk to the staff there if they have any concerns, any questions, any changes in the condition. And then we will usually ask them to call their visit nurses from the service provider organizations or the retirement home to call the service provider organization nurses if they have any concern or if they need assistance. But we are available to the care teams 24/7 if you have any questions, if you need any help. And then we have access to their primary care provider as well 24/7 if there's a need for any orders or prescription after hours. And I think that's kind of it for our team, Val.
Think so. I think that's where we ended. So thanks, Genevieve and Debbie. So there's just a few other resources that I'll highlight, and then some things that CHPCP does, my organization. And then we have a case study that we'll hopefully get some of your thoughts on. So, Genevieve talked about how her team works in collaboration with primary care providers. When folks are a bit closer to the end of life, there is multiple groups of community-based palliative care physicians who will provide primary palliative end-of-life care to patients. Again, this is there's a map on our website, and you can click on the geography. It's by postal code that these groups kind of work, and it would be a physician referral that would be required to get one of those teams involved. The Champlain Hospice Palliative Care Program is kind of heavily engaged in the education game, and so I'd encourage you to go onto our website. You'll get one of those irritating pop-ups, and to sign up for updates from us about the palliative care education that we offer. We're fortunate in Champlain that we do have some funds for palliative care education. So, for example, we purchase seats in Pallium Canada's Learning Essentials and Palliative Care courses. We offer a monthly series called the Thursday Evening Series with a variety of topics about palliative care. And then our team will provide custom education related to the palliative approach to care, grief and bereavement, and advanced care planning, if that would be helpful for your teams. A lot of our presentations that we have, so things that we've run on Thursday Evening Series, are available on our YouTube channel. So, I said we're not in the direct care provision game. The only program that we have that we do offer directly to, healthcare consumers is our practical caregiver education program. And so this would be for family and friends who are providing direct care to somebody who's living with serious or life-threatening illness. It is very practical focused. And so it's a series of 5 weeks, 2 hours a week, where we go into topics like the role of the caregiver, advanced care planning, the palliative approach to care, information about transfers, providing hygiene care, changes to expect at the end of life, and then how to support somebody who's experiencing those changes, medication management, and then some information on self-care. We've also got information and resources on our website that I've linked to there. And then I think the last thing I'll mention is that, if your team needed some support around the losses that they've experienced, we have worked with groups, so long-term care homes, Rotary homes, Ottawa Inner City. My colleague Tara has worked with staff that have experienced losses, and so better equipping them to continue to do the important work that they do. So we're going to do a quick case study, and hopefully we'll get your thoughts on some approaches to care for this person who living in a retirement home. So Mr. M is a 91-year-old retired Air Force officer. cared for his wife who had dementia until her death in 2013 near Belleville. In 2017, he moved to Ottawa to be closer to his daughter and her family, and he lived an active life at his retirement home. His medical history includes moderate COPD, gastroesophageal reflux, and hypertension that were managed medically. Then during the summer of 2021, he started having trouble with worsening indigestion and epigastric pain. A trial of an increased dose of PPI medications was unsuccessful, and the family doctor at the retirement home requested an endoscopy at the community clinic, which was refused because of his age. So recognizing the need to expedite the follow-up, Mr. M and his daughter went to the emergency department. He was seen and assessed by a nurse practitioner, and an urgent GI consult was put in, and a trial of a different PPI was started. When he had the endoscopy, a large 10-centimeter long tumor was found in his esophagus, and then further staging tests revealed metastases to the bone, liver, adrenals, and lungs. He'd been referred to a gerontology medical oncologist and a radiation oncologist. The decision was made to have palliative radiation to the esophageal tumor. He requested a MAID referral at that time of consultation, wanting to die at home with his dog by his side. So based on what we shared with you so far today, what supports could be put in place for Mr. M and his family? What is the role of the retirement home in care planning and service delivery to support Mr. M and his family, given his wish to die at home? And then what resources could be accessed to support the team at the retirement home? So I'm just thinking I might stop sharing because it's hard for me to see hands up and chat. But if folks want to put their hands up and go ahead and unmute. So what supports could be put in place? What is the role of the retirement home? And what resources could be accessed to support the team in the retirement home? Anyone want to take a stab? DOC?
Sorry, I couldn't change my name.
No worries.
I'm the Director of Care at Rockland Manor. I do not have a questions, but I do want to say that I've worked with RPCT and Debbie, and RPCT has been amazing. I mean, if any Director of Care requires any anything in regards to palliative, it's amazing working with you guys. And yeah, that's all I wanted to say.
So would you suggest that that we get RPCT involved in the care of Mr. M?
Mr. M?
In the case study that we just talked about, would you suggest we get them involved?
Yeah, absolutely.
Okay. And you mentioned, Debbie, you know, if we were to think about home care services, what jumps to mind as what would be important for Mr. M's care?
Probably put some PAL nursing in place.
Palliative care nursing. Thanks, Lauren. So a couple of questions. What would be the role of the retirement home? So folks from retirement homes, what do you see as your role in care planning and service delivery to support him and his family, given he wants to die at the retirement home?
Hi there, it's Tina here.
Hi, Tina.
Hi, we have a few in Champlain. Lynn is wonderful to have as a resource for us, for these residents to stay in our home. I think the biggest role for me is just ensuring that all the pieces are there and that we kind of chip in where we're needed, where Champlain doesn't fit in, and to ensure that the family is aware if they miss communication with you guys as well. So
Thanks, Tina. Is there anything else that people would want to add about the role of the retirement home?
Perhaps I could add, Val, to ensure that the team is aware of what the goals are for him to remain at the home.
Oh, yes, sorry.
That's great. Anything else that people want to add? Sorry, I just lost kind of my little screen there with people's faces. So Debbie or Genevieve, I'll ask you guys to call on people. Can people can see the slides again?
We can.
Okay.
I'm just wondering for the care coordinators from home and community care that are on here, is there anything that you think could help support this, help support Mr. M and his family in order to remain at the retirement home?
Well, oftentimes one of the big things is the equipment piece.
Mm.
So a lot of the times when my retirement homes are reaching out, it's about hospital beds or the bedside tables kind of thing. So whether we rent them or whether there's any local resources. So I'm more out like Dundas County. So there's a hospice there that'll lend out equipment, things like that. So often the equipment is a big piece. And then, of course, obviously too, in terms of pain management, is the GP on board? Are there orders, like all the things that come with the symptom management and all those different pieces? So it's really just making sure that, well, one, the referral's been made and that we're involved, and two, then making sure that we know what's needed.
Thanks, Lauren.
Awesome.
Are there any other hands up? Debbie or Genevieve, anybody else have anything they want to add?
I'm not seeing any, Val.
Okay, so we'll just go to the outcome. So Mr. M was under the care of the retirement home MD and RPCT until he had made at the retirement home with his family at his bedside. Mr. M had a home care coordinator, sorry for the typos there, who arranged nursing visits weekly up until the last week of his life when visits were switched to daily. He had CAD pumps for an opioid infusion and subcutaneous hypodermic lysis. Staff from the retirement home came to say goodbye to Mr. M in the days before he died and provided the family with space to gather, food, and emotional support. When the funeral home came, staff accompanied his body out the front door of the retirement home. So now I'm definitely going to stop sharing so I can see all the little boxes. So yeah, I think Debbie, Genevieve, and I are happy to entertain any questions or comments or, challenging situations that you wish you could wave a magic wand and maybe do differently, or things that, like, I can't remember who shared, if it was Tina that shared about how well things can go if we get all kind of hands on deck and involved. So I'll turn it over to you.
Well, one of the things I just wanted to add is with regard to medical assistance in dying, that is one of the things that home and community care support services does help facilitate as well, with the linkage with the MAID network, or just working with the physicians or the nurse practitioners with regard to navigating the request and the provision. We can certainly work with our nursing service providers to help with the IV starts for that. And we've had several that have taken place in retirement homes, long-term care, as well as patients' homes. Thanks.
Thanks, Deb. There's often questions about that for sure. So that's kind of what we had planned to talk about. I would like to remind folks about our next session. It's January 17th. Kelly McBride from RPCT is going to be talking about pain assessment and management. And then through the winter and into the spring, we'll be covering topics such as dyspnea, GI symptoms, delirium, palliative emergencies, and then care at the end of life. So, you know, however you got this invitation, please be sure to share it with your colleagues. We may send out another irritating email with more information, with a reminder. But it was great to have 31 folks at our highest number today participate